you know that nearly 50% of people who suffer a heart attack show no signs or symptoms that doctors relate to heart disease? And they have normal cholesterol in a basic lipid panel. My dad was millimeters away from a heart attack when we discovered that he was at risk. My dad is actually here right now to share his heart disease journey from diagnosis to treatment, along with his new lead interventional cardiologist, Dr. Joseph Yang with the VA in San Francisco, and his internal medicine and functional medicine practitioner, Wellspring Natural Medicine's Dr. Adrian Hines, who set him up with the ultimate blood work, diet, and supplements that changed the course of his blood work in just 1 year. Welcome, everyone. I think I want to start with my dad. Thanks for getting up early for this. Dad, you know, you went to your general practitioner complaining of chest pain that you likened to heartburn. And then we asked, well, could it actually not be heartburn? Maybe it could be signs of a heart attack, because your mom and dad, my grandma and grandpa, had heart disease. And she said what?
Well, Kim, she said, you have a normal or good cholesterol in the basic lipid panel, so you can't be at risk. Mm-hmm. We pushed for an EKG anyhow. We found an abnormality, trying to pronounce my words this morning, and after a nuclear stress test confirmed narrowing in my arteries, which the doctor said the next steps was an angiogram.
Okay, and so, you know, what happened, you know, at that point? I mean, there was no discussion of approaches, no tools, no techniques. Prior to this angiogram, your first cardiologist wanted to just throw you on the table because of a cancellation the next day. You didn't even know the location of this narrowing in your coronary vessels or their treatment strategies. You didn't even know the doctor. Were you actually ready?
No, it scared the H out of me. Diagnosis is one thing, but waking up to the potential of having a half a dozen stents was scary, and especially done by a doctor I have never met before doing the procedure. So we requested a 256 slice CT scan to get the 3D modeling of the heart and have a productive discussion with the doctors about what needed to be addressed. Also, we were specific as to what atherectomy devices and stents we preferred. We ended up agreeing on only one area. The 95% blockage in the circumflex was critical, and to make lifestyle modifications and see how my body reacts to the stent, medication, and diet changes.
And you did really well. And then just 1 year later, you had another 256 slice CT scan, which showed actually a quick progression of plaque outside of those stents, including a 90% plus narrowing in your right coronary and a 70 to 80% long calcified narrowing in your LAD. But the cardiologist, your other cardiologist, the older one, said no treatment was needed. Why?
He just said I had no symptoms, which 40% of heart attack sufferers show no symptoms. Come back in 6 months for a nuclear stress test. So I went to the VA for a second opinion. That's where I was able to get referred to Dr. Joseph Yang, and he was very methodical in reviewing my data and in his approach. Mm-hmm. He reviewed the films and detailed his strategy. It just inspired confidence in me that he was the man for the job.
Yeah, and Dr. Yang, what surprised you about my dad's case? Kind of walk us through that two-pronged approach that you took, as well as what others could actually learn from it and use to facilitate a productive conversation with their own doctor.
Yeah, thanks, Kim, for having me. Hi, Bill. Good morning. Good morning to everybody else.
Good morning, doctor.
I'll say this. I think I'm lucky because, you know, it's easier to come in once you have all the information already in front of you, rather than meeting somebody for the first time and gathering all the information yourself. It's easy in hindsight to see what you think can be done. And so we had a lot of information when I saw Bill for the first time with my excellent nurse practitioner, Sarah Goodman, who helps take care of Bill with me. So you know, I think Bill is a very active guy at baseline and very functional. So in my experience, patients like that a lot of times can develop, can look quote unquote asymptomatic because they've just been so functional at baseline, and they did so much activity, and they don't even realize themselves that they're slowing down because of coronary disease. And so we saw the CT scan. We were able to look at that and review it, and then we said that the next step is probably to repeat the angiogram, and we didn't know what it was going to look like either, change, but we've discussed that these are the things that we'll look for, and then we'll make a decision at the time based on what we think we're going to find. I'll say also, I think I'm lucky that as an interventionalist, I get to see a lot of my patients before doing a procedure on them. So Bill and I and Kim, we had spoken at length with Sarah, but I realize that not all. I have many patients that I take care of as well that are referred from my colleagues that I may be meeting for the first time on the day of the procedure, but we try to talk and go over everything that we're thinking about and why they were referred before the procedure as well.
And so you want to show us a little bit of the procedure? I'm not sure if you have both of the procedures, but we'd love to see exactly what you did during the, the angiograms that others could learn from, to see what actually happens and what are the possibilities and why you make the decisions you do while the patient is on the table.
These are my disclosures. I don't have any financial conflicts. I do have to just say that the opinions here are my own because I do work for the government and not from the U.S. government itself. And that Bill has agreed to show it. So you heard Bill's story. I first met Bill after he had already been stented in the left circumflex, which we'll look at, and then he had a repeat CAT scan done, including which Dr. Gupta mentioned. He had CT FFR done, which is fractional flow reserve. It tries to mimic a functional study based on the imaging to see whether or not the imaging suggests that the blood flow is limited by a blockage. And so we had already had this, and we had a long discussion in clinic with, as I mentioned, with my nurse practitioner and myself about what our plans were. And the first thing to do was to take another look. So as Dr. Gupta had shown you, we start with cardiac catheterization. We did this from the radial approach to the wrist artery. And this is a catheter here in the right coronary artery, as you can see. And the arrows show this kind of severe blockage in the mid portion of the right coronary. We then flipped around to the other side and used a different catheter engaged the left coronary, of which there is the left main that branches in most people into the left anterior descending and the left circumflex. Bill had a stent placed in the left circumflex before, and the CT FFR suggested that there was flow-limiting stenosis in the left anterior descending. And because there's two arteries on this side, we take multiple views in general. And the arrows here point to the kind of 70 to 80% stenosis in the LAD that was positive by the FFR analysis. And then here, these yellow arrows point to the circumflex stent that was placed elsewhere, and it looks awesome, just honestly. So Bill had a great result there. So the next steps that we had on the table, and this is what happens sometimes when we do the diagnostic test, and then we go into, we're already in the wrist artery with catheters, the patient's already sedated, and we have a discussion about what the next plans are, how to tackle each artery, what to do next, in discussion with my team at the time. And with Bill was that I thought angiographically the right coronary artery was the most severe. It was very calcified, so I think it was probably a little bit, once you have a lot of calcium in your arteries, the CAT scan, the x-rays can't penetrate the calcium as well. So CT angiography sometimes can be difficult. But I thought that the right coronary was the most severe. And I also thought that the left anterior descending anatomy could potentially be complex. I was not planning a complex approach for it, but kind of you always have to be ready. So based on that decision, our thought was, we've spent some time already to take the pictures. We spent some contrast dye and x-ray exposure to Bill at this time already. So we should do probably one artery first, fix that, see how he does, and then discuss down the road whether or not we should come back and do the other one. And because the right coronary is more severe, I thought that the best thing to do was to fix that one first. So this is just us with guiding catheters. This is a catheter in the artery from the wrist. This is a wire and then a balloon here doing angioplasty first. This is deployment of the stent. And this is the after images. Remember that the blockage was here. And the artery looks great. It's completely open now. It's nice and smooth, and we got a very good result. Bill actually tolerated the procedure really well, and we were able to do same-day discharge, such that Kim came and picked him up a few hours after the procedure, and he went home and was doing great. So we met in clinic and discussed a few weeks after that about whether or not we should proceed with the LAD. It's probably the most important artery in the heart. We had a functional study based on the CT that suggested that was positive, suggesting it was flow limiting. So we discussed what to do. I'll go back and show you the pictures in a little bit, but it was pretty calcified based on the CT scan that we had. So I thought best probably to debulk the plaque a little bit with atherectomy, which we commonly do here at the VA hospital here. I also thought that there's a side branch coming off of it that I wasn't planning to stent, but certainly stenting across it can shift the plaque into that side branch. So you have to be ready to work on that if the issues arise. And then I was planning to do intravascular imaging because the artery is very big, and to make sure that we got a good result. So the first thing we did was re-looked at our handiwork from the first time before, and the stents still look really good, as you expect a few weeks later. Came over here, and again, this is now us getting ready to work. You can see the left anterior descending it's quite big here, and then it gets very narrowed here. You can't see the calcium shadow outline, but it's pretty heavily calcified. This is a different view where the left anterior descending comes down the front of the page here, and then you can see there's a severe narrowing here and here. So this is the actual stenting procedure, some still images from it. You can see that this actually is the atherectomy crown. We used something called orbital atherectomy, which is a spinning crown, and it rotates and they say kind of jump ropes and makes a bigger loop through the artery in a safe way because it shaves down the calcium. And then, as I mentioned, there's a wire in the main artery, the left anterior descending, and a wire in the side branch to protect it. This is us ballooning. This is the first stent that was placed in the left anterior descending, and given the amount of plaque that there was, it actually took a second stent because the longest stent we have is 38 millimeters, and here is the second stent. This is us doing intravascular ultrasound. This is an ultrasound catheter to look at the artery from the inside. And then this is the final images. The artery is very beautiful, nice and smooth coming down the front. And here you can see it's much larger and wide open. And those are the results. And I'll just give you comparisons. This is the pre-right coronary artery, very narrowed here, and afterwards nice and smooth. And here is the pre and post again of the left anterior descending, where you see this very severe narrowing. It's nice and open here. The vessel itself is a little bit, widened here, and it kind of flutes down, but it's nice and smooth. And this is again the pre and post. So the next steps, Bill and Kim and Sarah and I, we've met a couple of times now to talk about what the next steps are. Stenting is great. It can decrease previous symptoms a lot. Potentially, it can decrease the risk of heart attacks in lesions that are positive by functional study. But no matter what, risk factor modification with Bill's great diet, his exercise, and medicines for coronary disease are the key next steps. And that's how we've agreed to proceed. And I'm hopeful that Bill will do really, really well with kind of a very, very, overall, very comprehensive medical management with us and with his other doctors. And thanks. And just to remind you that San Francisco VA has like the best view of any hospital in the country.
I love that. Yes, it does. And doctor, diet and supplementation, it's really, really important, as well as exercise, but it can only go so far in overcoming, the 40, 50, 60, 70, even 80 years of momentum that you have in diet and all that stuff. And so sometimes that plaque just continues to build for a while. And that's why medical therapy is also important, coupled with the diet, the supplements, etc. But you noticed a difference because of his diet and his supplements and such in the stents themselves. So while the plaque was building around, the stents remained clear because his blood work improved, correct?
I think it's potentially possible. I agree with everything you said. The other thing that you can't really run away from is your genes. So for Bill, with parents that both have coronary disease, that probably is a predisposing risk factor that no matter how good your blood work looks is an independent risk factor and something that we can't control. I think a lot of those things are are how you, I think the biggest point for me is, despite all the plaque buildup and all those things, Bill's never really had a heart attack. He had a, kind of an unstable angina presentation originally at the first hospital he went to. So but he's never actually had a heart attack. The heart pumping function is normal. So I think that all those things are very attributable to him at his age, which I won't reveal, helping him make it that far without having a heart attack. And it's our job working together to, to do our best to prevent him from having a heart attack.
Yes, thank you so much, Dr. Yang. Interventions in medical therapy can only go so far. Exercise, we mentioned diet and supplements, right? But exercise is also really important. Dad, how much do you exercise every single day, 5 days a week?
Well, 5 days a week, I'm up at 4:45 and meet my neighbor 2 houses up the street, and we do 4 to 5 miles walking, sub 20-minute mile doing the hills up off Las Colinas. Then I come back, and that takes whatever, and come back and do an upper and lower body workout, which includes weights, stretch, balance, 30 minutes on the elliptical. And after that, I come into my office and follow the heartmath.org program, heart to brain and energy meditations. Then I have my morning prayer, and then I do 6 sessions of Wim Hof's breathing exercises of 40 breaths on each exercise. And on the 6th set, as I do my last exhale and don't breathe, I drop down and do 50 push-ups. So
No, wait a minute.
Morning.
How old are you, Dad? Dr. Yang
Gonna
wouldn't
be
say it, I
8
won't
and
say
10
it.
months.
Yeah, exactly. Oh my goodness, how many people do you know that does that? I'm sure Dr. Yang doesn't have that many patients then.
I don't do that myself. So Bill, you're making us look bad.
I can see Dr. Gupta's over there smiling as well. Dr. Gupta, you wish you had patients like him.
I wish I could do that.
No, I don't even either. And I'm literally a quarter of his age. We mentioned exercise, but also he's made some big diet changes that we talked about. Dr. Hines is here to talk about some of those factors that you can control as long as you know about them. Dr. Hines.
Hi, Kim. Thanks so much for having me. Bill, you're looking out of this world today. I love it. So yeah, as far as some factors, Dr. Yang just mentioned genetics. So for Bill, one of the really important key factors for him, having an MTHFR SNP. So that unfortunately is something we're born with. And so for him, that is one we really needed to address. Before he came to see me at the office, he was doing a plant-based diet, which is absolutely fabulous. But unfortunately for him and this MTHFR SNP, it wasn't working the best because he wasn't getting really good B vitamins that he needed for this methylation cycle. And that methylation cycle is responsible for producing our homocysteine. And homocysteine is naturally produced, but in large quantities, it can be a really kind of nasty molecule and go around and cause some abrasions and nasty things in the arteries. And that, of course, can lead to more plaquing, more atherosclerosis, which we don't want. So knowing that genetic factor, that was really key and important for him to change some of the things in the diet. So that's another thing that all patients that are on this call even today, or clinicians that want to add that into their diet, looking at genetics is really amazing and important, not only for genetic SNPs in MTHFR or some of the other detoxification pathways in the liver, but also looking at genetics and how patients will break down their medications. People that are on statins or any antihypertensive medications, it's really important to know how their genetics play into how they metabolize these medications. Because some people are poor metabolizers, others metabolize super fast. And so it just changes the way the medication will work in those patients. So I think that's really important to add in. As far as genetics too, we're going to look at lipoprotein A, and lipoprotein A is really going to tell us if we're having more of a genetic risk for developing more plaquing and atherosclerosis. So that's another really easy one that patients can look at in their blood. The other thing that we like to talk about around here is haptoglobin, because haptoglobin isn't really talked about a whole lot, but we really love it because a lot of our patients do have kind of this, a lot of patients will come in and have type 2 diabetes along with their PAD or coronary artery disease. And with this having a pre-existing condition of type 2 diabetes, it's really important to look at haptoglobin gene, because with this, if we do have a change in haptoglobin in that SNP there, then some patients actually respond really well to something as simple as vitamin E supplementation. The vitamin E works as an amazing antioxidant for these patients and really helps bring down their risk of developing any more PAD or progression of their PAD or atherosclerosis, anything like that. So those are really important genetic components that, we're born with. So some things we're going to have to work around, but there are ways to work around things. With MTHFR, we have to make sure we're really on our B vitamins. We really want to make sure we are taking in magnesium to help in that cycle. So there's really amazing things that we can do once we know the information. So information really is power to our patients. So I am always asking the question why. And I think as patients, that is a really amazing thing for you to ask from your physicians as well, is why is this happening? What is the root cause of things? And if it is a genetic component, then there's ways that we can potentially work around things. The other really important thing to look at, and we discussed with your dad's case as well, is looking at some inflammation markers. C-reactive protein is an amazing marker to look at inflammation, but it is sometimes misread by physicians in that there are two different things that we're going to look at in that one marker. We're going to look at it for systemic inflammation, but it will also be a sign of acute infection as well. So sometimes it can be misread by physicians. I've seen it time and time in my office where patients will come in and they'll go, oh, my autoimmune condition is flaring up, my CRP's through the roof. And I'm going, no, that's an actual infection. So we've got to treat that part of things. That brings things down. So that's another thing to look at for these patients, is to do a CRP. It's really an easy peasy blood test that they can add on to any of their routine labs, because again, as you discussed earlier, most people can have a normal lipid panel, and they are probably not exercising as much as Bill, because that is absolutely amazing. But they can have normal lipid panel, and it just doesn't tell us enough information. So that's another way of looking at things. I add on to all of my patients, I add on LP-PLA2, because I want to see not only are they dealing with systemic inflammation, but are they dealing with inflammation specifically in the arteries? And LP-PLA2 will give us that information. And so that really tells me, all right, if we're dealing with inflammation, is it coming from other spots or is it specifically vascular? So that's another thing that can easily be added on to routine blood work. We mentioned earlier type 2 diabetes. Again, we want to make sure we look at that A1C, and I always look at fasting insulin because I want to see what insulin is actually doing during that normal process.
And what about, we mentioned earlier in terms of the basic lipid panel, and that about 50% of people who suffer a heart attack have normal cholesterol in a basic lipid panel. What more should I think everybody over 50 request of their doctor to determine their actual risk if they do have normal cholesterol and maybe they have some hereditary factors involved?
Great question. So I love looking at lipid fractionation. So having a normal lipid panel is great, and your LDLs may be wonderful, which LDLs are going to be notorious bad cholesterol, right? But it's actually the particle size of these LDLs that's really important. If we have big fluffy LDLs that look like fabulous little clouds, then they are less likely to be atherogenic. If we have really small dense particles, then those are going to be the ones we really want to worry about more. So the lipid fractionation is going to be really important to look at. It also is going to tell us, are we dealing with more problems with reabsorption, because we are going to reabsorb lipids from the GI tract. That's another thing that normally happens. Some patients are going to have a more likely to absorb things, absorb your lipids more than others, and that's going to be a genetic component to those. So with those patients, we really have to be careful of binding up and eliminating those lipids through the GI tract so that they are not reabsorbed. There's plenty of fabulous things that we can do with supplementation to really help with that and make sure that that does bind and we're able to clear them out so they're not reabsorbed. But that's another really important one to look at as far as advanced testing. You can go through Boston Heart. They are going to have amazing advanced lipid panels. But again, you can do an NMR or a lipid fractionation through Quest or LabCorp, and those are easy ones to do.
And you mentioned supplementation, and especially when you have that high cholesterol reabsorption problem, our body, yes, reabsorbs some of that cholesterol anyway, but it's the amount of it that you have to be careful of. And a high soluble fiber diet is important. And you can, for example, with my dad, add maybe some psyllium to your diet to help with that. What other supplements do you recommend usually for your patients?
Absolutely. So psyllium's wonderful to get that good fiber in there to really help bind things up. The other one that I absolutely love for my patients is plant sterols, because these will really help with the cholesterol reabsorption factor of things. So that will help bind things up and clear them out. Your B vitamins are really going to be essential. Our B vitamins, not only for that methylation cycle, but they also help in the detoxification pathways in our liver. So they're really important. And it's going to help move that homocysteine into glutathione. And glutathione is the most powerful antioxidant in our body. We really want to have more antioxidants so we can get rid of that free radical inflammatory cascade that's going on in the body. You can do other things to really help with the blood flow. Omegas are going to be great for helping thin things out. They'll also help with the antioxidant part of things. We can add in resveratrol, ECG, GC. So those are going to be really good ones to add in. N-acetylcysteine is the precursor to glutathione. So that will be one you can add in as well. It really kind of depends on the patient and the case, because everybody is individualized in my practice. And so obviously dosage and things are going to change. Working on blood sugar, if we have problems with type 2 diabetes, that's going to be really important. But making sure that they're on things with their diet as well, because that really is the biggest component. I could give you supplements until the cows come home, but if your diet is not good, you are not going to out supplement a bad diet. Same with, you're not going to out exercise a bad diet. It's the same thing. So diet is really going to be key for all of these patients, is getting that under control.
And determine whether or not you are getting the nutrients that you do need. I mean, a lot of times you just kind of know, because you know if you're eating the burgers and fries and everything else, that you're probably not, if that's the main staple of your diet, it's probably, you're not getting the nutrients you need. But it's really important to request to determine whether or not you're getting your nutrients, some sort of micronutrient test, blood work. But then it's also important to do that because a lot of the pharmaceuticals that doctors recommend when you do have cardiovascular disease or peripheral artery disease, they can actually deplete nutrients in your body. So these are critical tests, right? Can you be more specific in terms of the actual tests like potassium and sodium and such that people should request of their doctors?
Absolutely. So a micronutrient test is what you're talking about. And a micronutrient test is going to have not only our vitamin levels, but our mineral levels, proteins, amino acids, omegas. It depends on the extent of the micronutrient test as to how much of these components they're going to cover. But a good micronutrient test is going to cover all of those. I love looking at micronutrient tests because not only does it tell me where the patient needs extra help, but it also tells me if that vitamin that they got from CVS is actually working. So that's another really good test for all these patients that are like, I'm on all of these supplements and I don't feel any better. Well, maybe it's the quality of the supplements that you're taking, and a micronutrient test will give you that information. As far as medications go, statins are notorious for depleting CoQ10. So any of my patients that are on statins, one of the first things I ask them is, hey, do you have any like stinging and pain in your legs? Does it feel like you've ran a marathon when you just walked to the mailbox? Because if that's the case, most likely it's CoQ10 deficiency. So we can measure CoQ10 in the blood really easily. And that is one that a statin is going to deplete. Statins will also deplete our vitamin D to lesser of a degree, but it'll also deplete our selenium containing proteins. Selenium is really important for a thyroid. So again, we can be on a statin and that can cascade into a thyroid problem because now we're not able to convert our thyroid hormones because we have depleted the selenium we need to work for our thyroid. So it can be this cascade effect of nutrient depletion causing other organ systems to be affected from a medication. So that's why it's really important to look at where those are so we can supplement in. And you can supplement in with not only a medication or a supplement over the counter, but you can also look and see what food sources you can add into your diet that will help support those nutrients that you're missing.
And I know for my mom, even with her blood pressure drug, that was depleting some critical minerals as well.
Absolutely. Yeah. So you're going to have, most drugs are going to have some kind of effect. So we really want to look and see, it depends on what has been documented, the actual nutrient deficiency, but they're going to have some kind of effect. And again, genetics play a component in that. So that's why a micronutrient test is really important to look at.
Thank you so much, Dr. Hines. We really appreciate you.